the left brachiocephalic vein will join the right brachiocephalic vein, which will form the SVC, which will ultimately drain into the right atrium. Here in the portal system, we have umbilical vein, which gives rise to the ductus venosus. We have hepatic veins and IVC, which they form a subdiaphragmatic vestibule, and it is opening into the right atrium. We have one more vein from the abdomen, that is azygous vein, which drains into the SVC. So we require different planes for evaluation of the venous system. So we will see one by one. So the first plane, that is the umbilicoportal system. So this is the same view as the abdominal circumference view. So here we have main portal vein, which is joining the portal sinus, and it is giving rise to right portal vein, that is dividing into anterior and the left portal vein. And the umbilical vein here up to the level of inferior left portal vein. Now it is known as the left portal vein, which has three branches, that is the medial portal left portal vein, inferior left portal vein, and the superior left portal vein. The umbilical vein and the portal vein, then it is continuing as in the straight line, that is ductus venosus, and ultimately it joins into the right atrium. Subdiaphragmatic vestibule. So this is the video showing the portal system anatomy. This is the umbilical vein, this is the inferior left portal vein, this is the superior left portal vein. On the right side we have medial left portal vein. This is the portal sinus, right portal vein, posterior and anterior parts. This is beautifully demonstrated on HD power flow. The three branches of portal vein, left portal vein, that is the portal sinus. We have anterior and the posterior right portal vein. There is the ductus venosus, and we have main portal vein, and there is a formation of X. This is with the slow flow, giving the same information. So in stick we can also demonstrate beautiful anatomy of the portal system. Here this is the umbilical vein, inferior left portal vein, superior left portal vein. This is the medial left portal vein. This is the portal sinus, that is the right portal vein dividing into anterior and the posterior left portal veins. That is the main portal vein, that is the portal X, and that is the ductus venosus. Now there are three variations. It can either joining as a T or X or H. Okay, ultimately they are the variations. This is the most common type and this is the least common. So this is an example of H type connection, that is also known as type 3. So we have the portal sinus, which is continuing as the anterior right portal vein, and the main portal vein, it is continuing as the posterior right portal vein. There is no right portal vein, and there is a small connection between these two parallel venous outflow venous channels, that is the H. So this is H type. So this is nothing but the normal variation. Coming to the next plane, that is one plane above, that is the hepatic vein plane, that is the left, middle and the right hepatic veins. So here we can see left, middle and right, and this is the IVC. All three forms the subdiaphragmatic vestibule. Again, this is the slow flow technique. Here we can see the three hepatic veins and also the ductus venosus and IVC. They are formed subdiaphragmatic vestibule. This is the stick image showing the all three hepatic veins, umbilical vein, portal vein, and this is the ductus venosus. The star is subdiaphragmatic vestibule. Coming to the one plane above, that is the coronary sinus plane. This is seen just below the four chamber view. Here, I mean, this is in this book it is given that at the level of pulmonary veins, but if you see for pulmonary veins, it is not the coronary sinus plane because it is just below that. So this is the normal coronary sinus. Here you don't see the normal left atrium, and the diameter is ranging from 1 to 3 millimeters. If it is more than 3 millimeters, it is dilated, and this is the video showing the same. Here we can see there is a So how to differentiate between ASD1 and coronary sinus? Because if you see at the level of pulmonary veins, that is the at that level of the crux will be seen, and if there is a defect, then it is ASD1, and here it is below that level, so that is not, this is coronary sinus. You may get confused when the coronary sinus is dilated. Coming to the next plane, that is the pulmonary vein plane. So this is at the 4-chamber view. Here we can see at this level we can see inferior pulmonary veins. So it is best seen on the lateral 4-chamber view. So you can see the both pulmonary vein, inferior pulmonary veins joining into the left atrium, and this is with the power Doppler. Here we can see both pulmonary. If you angle somewhat, you can see all 4 pulmonary veins draining into one, and this is the stick volume showing all 4 pulmonary veins draining into the left atrium. Now coming to the SVC azygous vein, this is at the 3-vessel trachea view. So we have a small vein joining into the SVC. On the color Doppler with low PRF, we can see the azygous vein is joining. So at 3-vessel trachea view, we don't have 2 arches, we have 3 arches. One is ductal arch, one is aortic arch, and one is azygous arch. It can be seen on sagittal view also. Here we can see this is the azygous vein arching and joining to the superior vena cava. This is the superior vena cava, this is the azygous vein. Coming to the one plane above, that is brachiocephalic vein at the level just above the 3-vessel trachea view. So here we can see it is posterior to the thymus, and you can see the brachiocephalic branches of the aorta. So that is the same depicted in my case. So this is your left brachiocephalic vein, this is the branches of aorta. Remember, this is a practical point. Right subclavian artery and the left brachiocephalic vein have same color. If it is reversed, there is only one diagnosis, that is absent right SVC. Sometimes we may see the brachiocephalic vein is not adjacent to the aorta, it is passing through the thymus. You can see it is in between the thymic tissue. This is nothing but the intrathymic course of the left brachiocephalic vein. This is a normal variant. The 7th plane is bicaval plane. Here this is the IVC, this is the right atrium, this is the SVC, and you can see the pyramidal shape of right atrial appendage. So this is with the color flow, we can see the IVC and SVC. Coming to IVC and ductus venosus. So this is your umbilical vein, intrahepatic course, giving rise to ductus venosus, which is a funnel shaped structure, narrow. That's why there is an increase in the velocity, which will give you aliasing. This is the hepatic vein, this is the IVC, and this is the subdiaphragmatic vestibule. So this is depicted in the stick volume. So coming to ductus venosus, it is a funnel shaped or the trumpet shaped structure. It, with the help of eustachian valve, the flow from the, because of high velocity, there are 2 streams of the blood flow. One from the IVC that has slow flow. So there will be 2 streams. Because of high velocity, it hit directly to the foramen oval flap and goes directly into the left atrium. And the flow from the IVC, because of this eustachian valve, it goes directly into the right atrium. So now I have tried to demonstrate it in my case. So this is the ductus venosus, this is the eustachian valve. So you can see the flow is directly over the flap of foramen oval and going into the left atrium. And this is from the IVC, it is going to the right atrium. So this is the video showing the same. So you can see ductus venosus flow directly hitting to the foramen flap and going into the left atrium. Now coming to the venous system abnormalities. So what can be the different systemic venous anomalies? So in abdominal venous system, we have persistent right umbilical vein varics, DV agenesis or abnormal connections of the DV, and portosystemic shunts. We can have persistent left SVC and interrupted IVC with azygous continuation. So we will discuss one by one. So coming to persistent right umbilical vein, as you know, this is the stomach. At the level of AC, the umbilical vein and the portal sinus goes away from the stomach, while in the PRUV it goes towards the stomach, and you have the gallbladder between the umbilical vein and the stomach. So this is a sign of persistent right umbilical vein. Coming to the embryology, we may know that this is the right umbilical vein and this is the left umbilical vein. Normally, right umbilical vein gets regressed and left umbilical vein remains. Instead of here, the left regresses and the right persistent. So here there is a GB and this is a umbilical vein that is coursing towards the stomach. So here is the GB, this is the umbilical vein and portal sinus going towards the stomach. So this is your persistent right umbilical vein. And here the branching pattern will be reversed. So here left portal vein will give rise to left anterior and left posterior portal vein. And the right portal vein will have inferior, medial and superior branches. So this is with color. And remember, we have to demonstrate the presence of ductus venosus here. So the USG findings, the umbilical vein is on the right side of the gallbladder, GB is between the vein and stomach. It always courses towards the stomach, and always look for intrahepatic portal system and ductus venosus. So what can be the associated anomalies? It can be associated with cardiac anomalies, like in 8% of the cases. It can be associated with left SVC, septal defects and conotruncal abnormalities, single umbilical artery in 7% of the cases, GUT abnormality in 6% of the cases, CNS 4% and genetic less than 1%. Prognosis, if it is isolated and connected to the portal system and presence of ductus venosus, it is considered as normal variant. If it is non-isolated, there is 9% chance of chromosomal problem. Now coming to umbilical vein varics. So as the term suggests, varics, it is a dilatation of the umbilical vein, intra-abdominal, extra-hepatic portion. It will take color, there will be color uptake on Doppler. What is the definition? If it is more than 9 millimeter of umbilical vein diameter, or if it is more than 1.5 times intra-abdominal umbilical vein diameter. So here we have a focal dilatation of the umbilical vein. So the intrahepatic portion measures 3.6 and the dilated portion measures 7. It is almost double. So this is a case of umbilical vein varics. This is stick imaging. We can see there is a focal dilatation of the umbilical vein. It has a correlation with small for gestational age, trisomy 21 and cardiac anomalies and fetal demise. But if it is not isolated, the risk of chromosomal anomalies and IUFD increases. But if it is isolated, it is not associated, it is considered as normal variant. So always, whenever we find one abnormal finding, look for the other. Coming to the umbilical agenesis and abnormal connection of the ductus system. So here again I am showing this is the ductus venosus. There is some aliasing there and it is joining to the subdiaphragmatic vestibule. So what can be the different venous ductus venosus anomalies? Either there can be blind ending umbilical vein. It can join the IVC directly below the subdiaphragmatic vestibule. It can directly go into the coronary sinus. There can be no there is extrahepatic bypass of the umbilical vein. It is draining directly into the right atrium, or the umbilical vein going directly into the IVC without ductus venosus formation, or it can drain into the iliac vein, iliac arteries, umbilical artery, iliac vein. Coming to the agenesis of DV and blind ending umbilical vein. So here the UV enters the liver, it connects to the portal system and appears to end blindly without any origin of ductus venosus. We have to rule out any intrahepatic portal systemic shunt is there or not. In 80% of the cases, it is associated with aneuploidy, mainly Down syndrome, cardiac anomalies and genetic syndromes. If it is isolated, it has a favorable outcome. And in this type of cases, portal system is always well developed. So here we have a case of at 18 weeks, we can see the umbilical vein is going, but we expect a ductus venosus to go like this, but we don't see any ductus venosus here. In axial view, we can see the portal system is well developed, we can see the portal X, but there is no aliasing channel is seen going towards the IVC. In the 3D stick volume, we can see there is umbilical vein, it is going down, but we expect a ductus venosus over here, but there is no ductus venosus. Another case, we can see the umbilical vein, but we expect ductus venosus over here, but we don't find any DV. So this is the blind ending umbilical vein with agenesis of ductus venosus. Now coming to the classification of ductus or umbilical portal system anomalies and shunts by Acheron et al. This is a landmark paper, you should read it. So in this they have divided into 3 types. Type 1 is umbilical systemic shunt, that is about 20%. Type 2 is DVSS or DV systemic shunt, that is about 43% of the cases. And type 3 is portosystemic shunt, in which it is subdivided into type 3A, it is intrahepatic portosystemic shunt, and type 3B, that is extrahepatic portosystemic shunt. So this is an example showing USS or the type 1 umbilical systemic shunt. Here the umbilical vein goes directly into the IVC. There is no narrow junction. Here the junction is wide open. Another example, the umbilical vein goes extrahepatically, going directly into the right atrium, and in the rare cases it goes directly into the iliac vein. Here in these cases we find dilated IVC. Coming to type 2, that is DVSS, here the umbilical vein goes directly into the IVC but with a narrow junction and aliasing. Here the junction is narrow. Coming to type 3A, that is intrahepatic portosystemic shunt. Here there is a connection between umbilical vein or the portal vein and the hepatic, one of the hepatic veins. Type 3B, that is the extrahepatic systemic shunt. Here there will be no portal system and the splenic vein or the main portal vein going directly into the IVC. So what should be the workup if you find any abnormal DV or umbilical vein connection? Look for the connecting site, whether it is wide or narrow. Then look for the markers of aneuploidies like trisomy 18, 13, 21, Turner syndrome, triploidy. Look for other syndromic markers like heterotaxy or Noonan syndrome. Do detailed fetal echo to rule out any other cardiac or venous anomalies. Thorough anomaly scan is needed to rule out any systemic involvement. Follow-up USG is required to look for the hydrops development, and second trimester scan is required to look for the portal system and venous anatomy. If none of the above abnormalities found, then the prognosis is generally good. So we will see the cases of the abnormal ductus connections. So here we can see there is umbilical vein which is going directly into the right atrium. In sagittal scan we can see the umbilical vein goes extrahepatic subdiaphragmatic route and goes directly into the right atrium. So these are the still image, and also whenever you find one vascular abnormality, look for other. There is a single umbilical artery. This is a stick imaging showing the umbilical vein going directly into the right atrium. Coming to case 4, here the umbilical vein is going into the IVC, but the junction is wide. We have also single umbilical artery. In the heart, as I told you earlier, do fetal echo. What you see is the AVSD. Here there is no crux, and in the systole we find linear insertion. So this is a AVSD. This is the stick image showing the single AV valve. And always look for portal system development is there or not. We don't find any portal branches as we described earlier. So in umbilical systemic shunt, usually there is no portal venous development. Coming to case 5, here this is at NT scan. The patient came, there is a small omphalocele, heterogeneous choroid plexus with choroid plexus cyst, multiple umbilical cord cyst. This is hernia, omphalocele with bowel herniation and multiple umbilical cord cyst. We can see the umbilical vein is going towards the renal vein, and the IVC above the renal vein is dilated. So here in sagittal view, we can see the umbilical vein coming and joining the renal vein. So here it is, the umbilical vein is directly joining the renal vein. So the portion above the renal vein of IVC is dilated, and also there was low set ears and micrognathia and single umbilical artery. This was a case of trisomy 18. So we had a case of umbilical vein draining directly into the renal veins. So type 1 umbilicosystemic shunt, the origin is umbilical vein. It can drainage into right atrium directly or systemic veins. There is complete absence of intrahepatic system, portal venous system in about 70% of the cases. Absence of DV is in about 100% of the cases. This patient later on develop IUGR, the higher chances of associated anomalies. Live birth happens only in 1/3 of the cases, and survival and alive well also in 1/3 of the cases. These cases tend to develop hydrops earlier, so follow-up is required. Coming to the next case, here we can see the umbilical vein which is joining the IVC, but there is a narrow junction and we see the aliasing. So there is a presence of ductus venosus. So here, if you can take the flow, it is typically showing the ductus venosus flow. This is the stick image showing. This is the subdiaphragmatic vestibule. It is miles below the subdiaphragmatic vestibule. So this is a case of ductus venosus systemic shunt. Always whenever there is an abnormal connection, look for the intrahepatic portal system. Here in this case we can see the portal X formation. So the portal system has well developed in this case. Sometimes in anti-scan also we can find such thing. So this is a ductus venosus systemic shunt. This was a doctor patient. So the umbilical vein with a narrow DV-like junction opening directly into the IVC. Another case, this case was followed and amniocentesis was done, which turned out to be normal. And this is the normal intrahepatic portal system development. This is an anomaly scan, normal portal system. So type 2, it has the origin is ductus venosus. It can drain into systemic vein or hepatic vein. The presence of intrahepatic system is in 100% of the cases. DV is present in 100% of the cases. But this type of anomalies have higher rate of aneuploidy in about 20 to 21% of the cases. Live birth and alive and well survivals are about 90% of the cases. Coming to next case here, this is the umbilical vein, this is the hepatic vein. We see an abnormal channel going. So here we can see this is the umbilical vein, this is the hepatic vein, and there is an abnormal connection between them. This is in the sagittal view. So here it is an abnormal channel connecting the hepatic vein and the umbilical vein. So this is an intrahepatic portosystemic shunt type 3A. So the presence of AHPVS in 100% of the cases, DV can be present in 75% of the cases. These patients tend to develop IUGR, associated anomalies is higher rate about 40% of the cases. Live birth happens in 100% of the cases, and postnatal abnormal liver function test in about 50% of the cases. In extrahepatic portosystemic shunt, there is absence of portal system in 50% of the cases. DV can be present in 25% of the cases, but this require 100% of the cases showing abnormal liver function test, and postnatal surgery is required in these cases. So it has a very bad prognosis. Now coming to persistent left SVC. So there is a failure of the left anterior and common cardinal veins to involute. So normally the anterior cardinal vein, it involutes, and there is a left brachiocephalic vein which joins the right brachiocephalic vein to form SVC. Here this does not involute, and there is no formation of bridging vein. So this will drain ultimately into the coronary sinus. So this is the most common variant of the thoracic venous system. The incidence is very common. It is about 1:350. It can be associated with cardiac anomalies in about 9% of the cases. Absence of the right SVC with persistent left SVC can be present. So this is an applied embryology. If this bridging vein, and this is the left anterior cardinal vein, normally this involutes and this persists. But if this does not involute and this is not formed, then you have persistent left SVC. Sometimes there is Instead of this involutes and it continues as the right brachiocephalic vein joins the left SVC and it drains into the coronary sinus. So there can be variation. So this is the normal anatomy. So there can be persistent left SVC with bridging vein also in about 8% of the cases. The most common presentation is persistent left SVC and there is no bridging vein. Or this can be absence of right SVC and persistent left SVC. So what can be the ultrasound findings? So they are different at different levels. So at the coronary sinus level, we have a dilated coronary sinus. At 4-chamber view, we see a cystic bleb in the left atrium. At 3-vessel trachea view, we have an additional vessel, and at the left brachiocephalic plane level, there is no bridging vein. So here a case, here we have a dilated coronary sinus. There is a bleb in the left left atrium. There is an extra vessel. So there is a dilatation of coronary sinus. There is a bleb in the left atrium, additional vessel, and there is no bridging vein. In parasagittal view, we can demonstrate like this. This is the left SVC draining into the coronary sinus. This is known as tobacco pipe sign. This is the same in the color Doppler. So here there is a coronary from left to right. There are two vessels, one left onto the left of the pulmonary artery. Both SVCs have same color and there is no bridging vein. If you take coronal view, you can see both left SVC and right SVC, but there is no bridging vein. Coming to case 2, here there are echogenic intracardiac foci. Is this normal? We see 3 vessels in 3-vessel trachea view. So we have 3 vessels. Is this normal? So we have P, A and S, but S is not here. It is on the left of the pulmonary artery. So this can be missed. So here this is the left. Normally the flow of the left brachiocephalic vein is left to right, but here it is from right to left, reversed. So this is the color Doppler image video showing the same. You have this and there is a reverse right brachiocephalic vein. So here there are 2 different opposite colors. This is right subclavian artery which is showing blue and brachiocephalic vein in the red. So there is only one diagnosis, that is absence of right SVC with persistence of left SVC. So here this is the coronal image showing right brachiocephalic vein joining the left brachiocephalic vein, forming the left SVC, which ultimately drains into the coronary sinus. Associated anomalies, cardiac, extracardiac and chromosomal. It can be associated with heterotaxy syndrome, left ventricular outflow tract obstruction like HLHS or coarctation of aorta. It can be associated with conotruncal anomalies, commonly TOF. Extracardiac, it can be associated with single umbilical artery and umbilical venous system abnormalities. In 9% of the cases, if it is not isolated, it can be associated with trisomy 21 and 18 and others. So whenever we see one abnormality, look for the other. So here is the case of persistent left SVC. Look for the other venous system. So here we have ductus venosus systemic shunt, umbilical vein draining into the IVC and single umbilical artery. Another case, this is, can we diagnose left persistent left SVC in NT? Yes. This is a case of absent nasal bone. Here in the first instance we think this is a AVSD, but this is not at the complete 4-chamber view. This is there, we can see there are 2, there is an additional vessel on the left of the pulmonary artery, and you can see 2 same colors and there is no bridging vein. So here this is the normal crux and there is a dilated coronary sinus. So this is a persistent left SVC with absent nasal bone at anti-scan. Counseling, if it is isolated, it is benign and good outcome. Reassure couple. Follow-up scan is required to look for the LV and LVOT size, because it is in 10 to 15% of the cases it can be associated with coarctation of aorta, and postnatal echo is must because to rule out coarctation of aorta. Now coming to interruption of IVC with azygous continuation, it is one of the most common abnormalities of the IVC. Interruption occurs at the intrahepatic level. The interrupted IVC typically connects with the azygous or hemiazygous vein. In rare condition, the interrupted IVC drain into dilated hemiazygous vein, which ultimately draining into persistent left SVC. In these cases, right SVC can be absent. So, in about 90% of the cases, it is mostly associated with left atrial isomerism, or it can be an isolated finding also. So, what can be the ultrasound findings? So, there is absence of IVC on AC view, double vessel sign in upper abdomen, and 4-chamber view. Look for the area behind the heart. Coronal view of the thorax shows double vessel sign, or also known as double barrel sign, which has opposite colors, we'll see in the case. And bicaval view shows the absence of IVC, which is entering into the right atrium. And I described this earlier. So, at the level of abdominal circumference level, at the stomach level, there is no IVC. We have dilated azygous vein. At the level of 4-chamber view, area behind the heart, there is a dilated azygous vein. So here in the bicaval view, this is normal anatomy. This is right atrium, SVC and IVC. Here in this case, there is no IVC because it is interrupted. In the coronal view, we see double barrel sign. One is aorta and azygous. On color Doppler also, we can see the different colors. So we have azygous vein going up cranially and aorta flow going down. So opposite colors. So this was a case. Here we don't find any SVC. The stomach is on the right side. Gallbladder is also on the right side. Instead, we are finding there are 2 dilated vessels, no IVC. On coronal view, there is double barrel sign, and there are different colors, opposite colors on color Doppler. And also there is a bradycardia, so it is common in left atrial isomerism. So this was a case of left atrial isomerism. Coming to associated anomalies and outcome, it is primarily related to left atrial isomerism. Chromosomally, there is almost absent of any chromosomal anomalies. If it is an isolated finding, it has a favorable outcome. Now coming to anomalies of the portal system. So we have 2 anomalies, that is total anomalous pulmonary venous connection or partial. So what is the definition? Total means all 4 pulmonary veins draining either directly into right atrium or indirectly via systemic veins, which ultimately drains into the right atrium. Or partial, 1, 2 or 3 drains into systemic circulation. So we have 4 types. The most common type is supracardiac TA-PVC, which is about 50% of the cases. Then cardiac type, which is about 16% of the cases. And infracardiac, the confluent vein goes directly into the portal system. And we can have mixed type also, that is about 9% of the cases. So TA-PVC, 2% live births with CHD. The incidence is 1:14,000 to 17,000. It can be isolated finding. It is commonly associated with right atrial isomerism. Rarely it can be associated with Holt-Oram, cat-eye syndrome or Noonan syndrome. Why it is difficult to suspect? Because only 2% of the cases diagnosed prenatally. Pulmonary veins are very tiny structures. There is limited blood flow through them. Only 25% of the cardiac output makes it from placenta to the lung, and it is notorious for looking as if they are connected to LA, but they are actually not. So what are the prenatal ultrasound features of TA-PVC? These are the features which are common to all the types. So there is no connection between pulmonary veins and left atrium. There is oval shaped left atrium with smooth wall. Normally we have left atrium with a flat surface, but if it is bald or there is a smooth wall, we can suspect that there is a confluent vein behind the left atrium, that is tweak sign. Increased area behind the heart, as Mansi said, and there is small LA to LV on 4-chamber view, which is in 60% of the cases, and there is less pulsatility of pulmonary vein. Now specific signs for different types. So supracardiac, there is a vertical vein, there is additional vessel seen on 3 vessel trachea view. There will be dilatation because it is draining into left brachiocephalic vein, so that will lead to dilatation of left brachiocephalic vein and superior vena cava. In cardiac type, there will be, it is draining into the coronary sinus, so there will be dilated coronary sinus. In infracardiac view, there is a vertical vein descending towards the liver and additional vessel in the liver cross section. Associated findings of isomerism, so we have to look for situs ambiguous and AVSD also. So there is a PLAS index, that is post LS space index. So normally this area from left atrium, distance from left atrial posterior wall to the aorta and aortic diameter. So always remember, it should be less than the aortic diameter. If it is more than the aortic diameter, then it is increased PLAS index. So that can be an indirect sign of TAPVC. So this is a case from Dr. Varun Thakur. So here we see an additional vessel and a dilated SVC. So by this view only we can say that we are dealing with supracardiac TAPVC, because in PLSVC we see small size bilateral SVCs, but here the SVC, which is almost equivalent to the size of aorta. So we are dealing with supracardiac TAPVC. So here there is a confluent vein and it's going here and joining the left brachiocephalic vein. So there is a dilated left brachiocephalic vein. So how to differentiate between TAPVC and PLSVC? So TAPVC, fourth vessel color away from the heart, while in PLSVC it is towards the heart, which is same as the right superior vena cava. Left brachiocephalic vein is present, usually absent in PLSVC. SVC and left brachiocephalic vein is dilated, while in right SVC and left SVC are of same size. The area behind the heart we see tweak sign, but here we see a cyst like in the left atrium, we see the cyst like or dilated coronary sinus, and fourth vessel is slightly behind, while in the at the same level of the right SVC. This is the case by my guru Dr. Adi sir. So here we can see there is a absence of right SVC. This is the persistent left SVC. And here, if you see the area behind, there is a confluent vein which is draining into the coronary sinus. So this is a case of cardiac TAPVC. Here we can see the confluent vein. This is the area behind the heart, and this is draining into the coronary sinus. Coming to next case, here this is the stomach is on the right side. This is the IVC and this is the aorta. They are on the same side. So this is known as juxtaposition of the IVC, and gallbladder is also on the right side. But here we can see there is an illegal occupant over here. This usually we don't see. On the 4-chamber view, we see a single atrial and single ventricular morphology. There is a huge gap between the aorta and the left atrium, and there is a tweak sign. So all the 4 pulmonary veins draining into the confluent vein. So there is a large distance between them, and this is the sagittal view showing this confluent vein going in inferiorly in the draining into the portal system. So this is the confluent vein going and connecting the portal system. So this was a case of infracardiac TAPVC. And it can be associated with, as we have seen that the stomach is on the right side. On the heart, there was a DORV with the pulmonary atresia as well. Coming to PAPVC, so it is a direct or indirect anomalous drainage of 1 or 2 or 3. It is very difficult to suspect prenatally. One such entity is Scimitar syndrome. There is a combination of hypoplasia of the right lung and right pulmonary artery and PAPVC. Here there is a dextroposition of the heart because of the hypoplastic right lung and the right inferior pulmonary veins draining into the IVC, and which gives rise to scimitar like, that is known as scimitar sign or the saber. So whenever we see a dextro position of the heart with the apex pointing towards the left, look for the lung if it is small, and then if you switch on the color, you can see the pulmonary vein draining into the IVC. So this is the scimitar vein. So this is the scimitar syndrome. So the prognosis depends on the anomalous venous connection and the presence of pulmonary venous obstruction and the volume of the right to left cardiac shunting. Prenatal series report worse outcomes than the neonatal series because there are associated cardiac abnormalities. And type 3 infracardiac TF-EVC has worse prognosis because there is a high association of pulmonary venous obstruction because it passes through the same ostium of esophagus. So take home points: congenital malformation of the venous system are complex and varied. Knowledge of embryonic development is key to understand in utero progress and prognosis. Whenever anomalies of cardinal, Fetal or umbilical system is diagnosed, thorough investigation of other segments of cardiovascular system is warranted. Anomalies of the venous system are not as rare it was formerly believed, and try to look at least 2 pulmonary veins in 4-chamber view which is draining into the left atrium. Thank you very much.
Thank you.